Before we get started with our morning speaker, Dr. Gary Bassett, there are some announcements that some people want to make, I'd like to make. Dr. Whitaker, do you want to come up and make an announcement, or can you do it from back there? Or? Well, we can do it. We'll do it again before you leave. So. What city are you in?
I don't remember.
Okay. All right.
Tarpon Springs, Florida.
Tarpon Springs, nice area.
We fly into Tampa. It's a very unusual, small group community.
What airport do you land in?
Tampa.
Okay.
For those of you that don't know, the national meeting for the Holistic Dental Association is going to be May 17th through 20th in Miami. And we got a full day of Doug Phillips and Hans Lechner is going to be there, and it's the emphasis on cavitation. So you might want to put that on your schedule. And if you call the hotel for the room rate for the meeting, the rooms are all gone. Tell them you're a AAA member, you get the same rate. There's plenty of rooms.
I'd like to introduce an exhibitor. I'll give her a few minutes. They're from Rocky Mountain Technologies. This is Penny.
Good morning, everybody. My name is Penny Snoots. I'm with Rocky Mountain Health Technologies, and you've already heard from a couple of the speakers a little bit about the anodyne for a therapy system. For those of you that are using it, you already know what this wonderful technology does. For those of you who aren't using it, I have to strongly encourage you to stop by and find out more about it. This infrared therapy system was featured on the Discovery Channel last October for the emerging technologies. It's really being picked up by all facets of healthcare, including dentistry, orthopedics, physical therapy, wound care, home health. In fact, even Blue Cross Blue Shield is now looking at protocols to progress the non-healing wounds with this wonderful technology. So it's really making a lot of headway in those venues. Because of this show and you all being here, I also have to encourage you, if you're willing to or ready to make more purchases, that you can get discounts on the technology for participating in the show. And if you haven't experienced this yet, please stop by, because even after just one treatment, most people are able to have a measurable difference in pain issues, whether it's headaches or sinus pressures, sprains or strains, anything like that. So, we're right out here. This is wonderful technology. It's easy to use. It's non-invasive. It's drug-free. And it really helps you with your practice by progressing your patients. They have a speedier healing process after surgery. All the patients feel is a mild warmth on the treatment pad, and they're able to continue self-administered care at home with this technology. But it's also a huge practice builder with you revenue-wise, because it's got legitimate CPT codes. You can bill on your practice. But with the home systems, to help reduce the infection possibility with your post-surgical patients, you're able to also increase your revenue stream by buying these systems and renting them or leasing them out to your patients so that they can get better. What we usually find out is that most of the patients don't want to let it go after they've utilized it. So, you again, by having these people heal faster and get better. Word of mouth is some of the best publicity you can have for your practice, and that's really what a lot of us see. So again, I also wanted to thank Chris and Carol for letting me come up here. And I've been in several different types of venues, and this is one of the friendliest groups I think I've ever been around. So hats off to all of you for making this a pleasurable experience. So, thank you very much. Please stop by and see us.
Isn't that Thomason guy associated with you somewhere?
Yes, he's.
I'm teasing.
You want a piece of me?
You've been promising that for a long time now. What, are you making a delivery back there or what? Another announcement that we're making. Tapes will be available. You see this young gentleman here with, he's starting to get more gray hair than me. Chris, he's been doing the taping for years. And the tapes of this weekend's seminar will be available. And if you order them here, the whole video set will be $270. After that, it's $300 plus shipping. So if you order while you're here, it's $270 including the shipping. Anytime after this weekend, it's $300 plus shipping. Any other questions before we start the next lecture? I'm going to introduce the next guest speaker, Dr. Gary Bassett, a gentleman I've known since I graduated from medical school. That was in the days before Prozac and I think running water and electricity. Gary was involved. I'm not sure how I met you then, but well, I guess I met you I had been to some seminar as a dentist somewhere. And then I graduated from dental school, we kept in touch, and you invited me out to an interview in the San Francisco area. I flew across country, and I was very interested in the work you were doing. Gary has been involved in electroacupuncture for over 20 years, at least, I think. He trained with Dr. Ball in Germany. He had terminal illness, probably, I think, even flatlined at least 2 or 3 times, right? That's what you told me anyway, so I assume that's the case. And obviously you found out what modern medicine has its shortcomings. You've come back into my life in the last couple of months. You moved here to Reno, and over the last several years, he has gotten into, and he's become quite proficient in the field of nutrition. Today he's going to talk about detoxification pathways, and this is more geared toward your mercury patients. This is what we set this up for. But he's been seeing several of my patients, and he does an incredible workup, laboratory workup on blood as far as amino acid analysis. The detail is way over my head, and I suggest you pick his brains on that afterwards. But there's some very interesting work that he's doing. I think you'll find this seminar very interesting, his lecture very interesting. And without further ado, we'll get started on that. Dr. Gary Bassett.
Yep, I'm all set. Well, congratulations on getting here this morning. I've been to a couple of hundred seminars just like you are today, and I know how difficult it is getting up after 2 days of being pounded with new information and showing up for a 8:30 a.m. presentation, hopefully clear-eyed and clear-headed. First thing I wanted to do is make an announcement. In your packet, because I got one in mine, I saw this blue sheet. It says mini residency. And this is it's a training program that Chris is putting on, a 6-day intensive educational program on diagnosis and treatment of oral infections. I've been around the world, trained around the world. I've seen a lot of surgeons, I've seen a lot of biological dentists, and I have never seen anyone that even comes close to the quality, the integrity, the compassion that Chris Husser has for his patients and the work that he does. I'll tell you what, whatever price it is, you'll regain it back in a very short time. I would strongly suggest to you that you seriously consider attending this course with Dr. Husser, if you're at all serious about NICO infections. Okay, this morning we're going to talk about trying to get this to, it's working backwards, so it may take me a moment to get used to it. This morning we're going to talk about detoxification, improving detoxification pathways. And one of the, unfortunately, underutilized aspects of assessing detoxification, and that is laboratory testing. And we're going to talk about some tests that you might not otherwise think of in regard to assessing detoxification. I'm sure there many of you, if not all of you, are familiar with liver detoxification profiles that are offered, that are challenge tests and that sort of thing. And if any of you have used those to any extent, I'm sure you've also had the experience of having patients that did not do very well on challenge tests. There are other options, and there are some important options in regard to identifying detoxification pathways and finding out how you can enhance those for improvements in your patients, as well as alleviating some serious adverse side effects that may occur in the process of mercury removal, jaw infection removal, or cell wall deficient organism abnormalities, all sorts of things. Now, the first question is always asked, why should I test? I can make observations. Most of the tests that are available really don't give me the kind of detailed information that I should have. I know what's wrong with this patient. And there are some basic determining factors that outline the biochemical individuality of every patient that walks in the door. These are some of those aspects: genetic uniqueness, dietary factors, environment, drug therapy, and metabolic efficiency. Each individual operates differently. Each individual has different genetic structure. They react differently to stress. They live in different environments, they're at different ages, they're in different temperatures, and so on. All of these factors can modify how we present ourselves, how our metabolism functions. Now, it's pretty customary for the average physician, the average mainstream physician, to run a standard chemistry. And currently, this is a SMAC 12. Reason I put the SMAC 12 up there is that this is the only chemistry that a physician can run on a patient now without requiring medical necessity. Anything more than a SMAC 12 requires some specific medical necessity. If you've noticed, the laboratories nationwide now no longer provide comprehensive chemistry profiles. They've broken them all up, and you have to order them individually. Well, certainly part of the reason for that is that they make more money. But another part of the reason is that about two years ago now, almost 3 now, the federal government stepped in, and there was a substantial change that occurred amongst laboratories. Previously, laboratories were permitted to self-regulate regarding medical necessity. And they were the ones who determined within their own organizations whether or not a certain test or procedure was appropriate, testing procedure was appropriate in a given situation. Almost 3 years ago now, the federal government stepped in and they made a number of changes. One of them was to form a federally controlled board that now has taken away the power from the laboratories of self-regulation for medical necessity, and they determine what's medically necessary. Okay, well, that's just replacing one master with another, so to speak. However, what they also did at the same time was something that's not very well publicized. Previously, if you violated the medical necessity rule, you were potentially guilty of a misdemeanor. At that new regulation, almost 3 years ago now, that was changed to a felony. If it is determined that you, and there is no statute of limitations on it, by the way. So if it's determined that tomorrow, or last year, or 2 years ago, that you order tests that are determined by the federal board to be medically unnecessary, then you are potentially, you can potentially be charged with a felony crime. So in that scheme, what happened was the laboratories then restructured, broke down all of these comprehensive panels that they were using, and that's one of the reasons why they cut down on those and offer only profiles. Now, for some doctors, they'll compile those profiles, but interestingly enough, and I guess it's no surprise, the laboratories haven't been real communicative about telling doctors that when they order these comprehensive profiles, that if they aren't absolutely certain about their medical necessity, they're potentially guilty of a felony charge. Well, if you can imagine, this is virtually unenforceable nationwide. However, those of us in the laboratory business feel that this is another one of those sleepers that the federal government holds on to, so that at some point in the future, when they decide that you are doing something they don't like, they can come in and they've got an axe to hold over you. So be cautious. Be cautious in this regard. This is a normal blood test. Now, you notice that there are 2 highs on here, and those are on there for a very specific reason. The average physician would look at this blood chemistry test and say that there's no abnormalities, in spite of the fact that there are 2 highs. Now, those 2 highs aren't high enough to become a serious indicator of pathology, and they have relatively no indication for pathology whatsoever. An LDH of 310 is insignificant, and a uric acid of 8.4 is also relatively insignificant in regard to the standard medical interpretation. Well, there's one problem with that. This blood test happens to be laboratory test for this woman. Now you say, well, a SMAC 12, that's not enough information to tell anything on most people. Well, in fact, they ran batteries and batteries and batteries of tests on this woman. And the only abnormalities they found were the 2 that you saw on the panel before, and a slightly elevated T4, just barely out of reference range, which they determined also was insignificant. So the answer for this woman, this woman was 50 years old. She had been gaining weight steadily over a period of 30 years, and every attempt at diet and exercise and everything else that she tried was complete failure. So they decided to do gastric bypass surgery on her. Well, one of the problems in this kind of approach in regard to assessing laboratory chemistries is the reference range. The reference range is designed with the presumption that 97% of the population is healthy. Now, you know that's ludicrous. All you have to do is look around. 97% of our population isn't healthy. They may be walking, or they may be able to be dragged out of bed to stand on their feet, but 97% aren't healthy. It certainly doesn't fit the World Health Organization definition of health, which is complete function of physical, psychological, physiological, emotional operation. So there has to be some other standard or some other way of using the information that we get to be able to understand when things go wrong. And if in fact what you do is you take a different view of the same information, you can come up with a lot different interpretation. Now here what we have is a representation of highs and lows that came out on a blood chemistry. This isn't the previous patient. This is another. This is one with rheumatoid arthritis. And in fact, on this man's laboratory test, his doctors saw only that he had low white blood cell count and a elevated blood urea nitrogen. And once again, neither of them was terribly significant, not too far out of reference range. And so they really didn't know what to do with it, other than just to identify that based on symptomatology and some complement tests that in fact this was a rheumatoid patient. However, if you look at this information with a little bit different view, what you see is that there are a lot of irregularities and imbalances, that some of which may fall within what would be considered standard reference range, but nonetheless, within the scope of where they fall, they're clearly abnormal. Now in this representation, that which is green is that which is closest to the median, closest to what might be considered optimum. Thank you. However, what you see where it starts to turn from green to dark, that's questionable, and when it's red, it's clearly abnormal. So this is another way of representing data, and this kind of data can be very useful. Now, just to point out, this is just an item that you might not know about. Here we have a result of 5.38 for TSH, and the range being 0.35 to 5.5. Most laboratories still use that reference range. Some of them may use it down to maybe 5.0. Within the last several years, there have been a number of studies. 1997, there was a study called the Colorado Thyroid Disease Prevalence Study. And in that study, they determined that there were some estimated 13 million undiagnosed hypothyroid cases in the United States, which makes hypothyroidism and thyroid disorder as a greater subset equal in incidence, if not greater, than diabetes in this country. So that means thyroid disorder is a substantial problem, and that you ought to be seeing a lot of it, and you ought to be diagnosing a lot of it, and if you're not, you're missing something. Okay, well, so you might say, but everybody I get, their TSH falls within the reference range. Well, the American Society of Endocrinologists about 2 years ago issued a statement saying that any level of TSH that exceeds 2.0 should be in question for hypothyroid function. 2.0. Now, I'd be willing to bet that you have an awful lot of patients who have a TSH in excess of 2.0. However, all of this great information hasn't as yet filtered down to most laboratories. So the reference ranges aren't immutable. You have to take into consideration that sometimes these ranges are excessive. Yeah, got a question?
Does it change for a child or an adult?
In this case, no. Not in TSH. Okay, so this is the principle under which we're going to operate for the rest of this conversation this morning. Medicine is not only a science, it is an art. It does not consist of compounding pills and plasters. It deals with the very processes of life, which must be understood before they may be guided. And from that beginning, let's talk about definitions just for a moment. We talk a lot about balance, particularly in holistic or alternative medicine. And sometimes balance is not necessarily an advantageous thing. Balance is defined as the harmonious performance of functions. If you have a handicap, if you have an impairment, you have to overcompensate in some other area to regain balance. Now, does that mean that that's optimal function? No. Dynamic relations, those existing between two entities when one or both of them are moving or constantly changing. This is very much like the kind of work that we're trying to do in healthcare. And you might say a metaphor of this would be trying to hit a moving target with a bow and arrow from the back of a horse that's running. It's not an easy thing to do. You have to take and consider that the relationships of all of the processes in the human body have to be perceived in regard to a dynamic, and that these relationships have to be considered in regard to optimal function. Now, homeostasis is another term we knock around a lot. Homeostasis can be to our benefit, or it may not be to our benefit. If, in fact, we're trying to achieve balance, a homeostasis within the system, we're going to compensate. One of the easiest places to see this is where we may be calcium deficient. If we're calcium deficient, does the blood vary that much in calcium? No. It just pulls calcium from the bone. That's a homeostatic reaction. In that case, homeostasis is not a healthy thing. It's a survival means, but it's not necessarily healthy. So homeostasis is a term that you should be careful about in your use. It's not always the best thing for your patient. And another thing that also, and this is in fact one of the reasons that there are many kinesiologists who have difficulty accurately diagnosing conditions or identifying problems, and that's described by the term homeoresis. Now, homeoresis is the tendency to maintain a biological process along a particular pathway despite the operation of factors tending to divert it. In other words, inertia. You start down a certain path biochemically. If your body gets accustomed to that pathway, you're going to have a hard time changing it. So just supplying the appropriate level of nutrients for normal function may not change that selected pathway. You may have to use pharmacologic doses of whatever, drugs, nutrients, whatever it may be, or even therapies, to be able to modify the direction of that metabolic function so that you can bring it back to optimum. Well, what happens when this occurs? Your body's going to argue with you. Okay? It's going to resist it. So there are going to be some adverse responses. There are going to be changes that occur that are discomforting, and that can happen. Now, disease doesn't occur in the blink of an eye. Medical taxonomy, the practice of categorizing disease, would have us believe that in one moment, like a light switch, there is no disease, and in the next instant, all of a sudden, there's disease. And so if you have a reference range, for instance, of TSH of 0.35 to 5.5, and you get a TSH that comes back at 6.0, all of a sudden, that's disease entity. However, if it's 5.38, it's not. And of course, we know that's silly. The truth is that disease goes through a series of stages, a series of abnormalities, a series of changes that occur to lead to the condition of disease. By the way, I see some furious notes. If you have a stack of the notes, PowerPoint slides, you've got a copy of this on there. And if you don't, there's some still up here. So we move from an early stage, dietary inadequacy, to diminished tissue reserves, to decreased body fluid levels, to decreased functional levels in the tissues, then on to decreased activity of nutrient-dependent enzymes.
Carol has those.
Does she? Ah, excuse me. Sorry for the misinformation. We move to a functional change, and only then will we manifest clinical symptoms. Subsequently then, anatomical signs, and finally disease. Now the idea would be, if we wanted to be true practitioners, faithful to the concepts of Paracelsus, ideally we would want to catch this process somewhere earlier in the sequence. Not wait until we get to 7, 8, or 9, but somewhere down in 2, 3, or hopefully even, if we're smart enough, before there's any indication, catch it at number 1. Although in our society, that's virtually impossible now. Now, in laboratory testing, there are an awful lot of reasons why values might be distorted, including homeostatic regulation, dietary intake, diurnal variation, hemolysis, sample contamination, drugs, physiologic state, disease states, infections, nutrient interactions, hormonal status, inflammatory stress, physical exercise, specimen collection procedures, age, sex, ethnic group, accuracy and precision of an analytical method, weight loss, sensitivity and specificity of the analytical method. These are all the very reasons why using a single variable analysis is faulty. It's flawed. It is inappropriate to take a single variable such as TSH, look at whether or not it's in reference range or not, and make a diagnostic judgment. Now we know this, we're taught this, but you know what? We slip up. We pick up a laboratory test, and first thing we do is run down the list and see what's high and low. And then we gear our entire approach based on what we see in regard to those that are outside of reference range. There's a whole bunch of reasons why that's inappropriate. So what then is appropriate? Multifactorial analysis. You need to look at patterns of abnormalities. You need to look at variations or degrees of variation from some point. Now, the truth of the matter is, we know virtually nothing about health. We know an awful lot about disease and dysfunction, but we know very, very little about optimum function because there's been very little study done on it. Now, if you were to presume, okay, that we know something about health in general, how much do we know about individual optimal function? My biochemical demand for vitamin B12 when I'm feeling well could be as much as 1,000 times your biochemical need for vitamin B12 when you're feeling well. Now, how do you determine that? By looking at someone? Or by assessing functional dynamics from a multifactorial view? Obviously, the latter is the only. Now, there are a number of other complications in regard to complementing nutritional status. And one of them has to do with antagonism. An antagonist is one who opposes and actively competes with another, an adversary. In pharmacology, it's a drug that counteracts or neutralizes another drug. So now let's look at calcium just as an example. All of these substances, sodium, potassium, cortisone, aluminum, magnesium, phosphorus, manganese, zinc, and fluoride, all antagonize the assimilation of calcium in our diet. They all antagonize the assimilation of calcium in a nutritional supplement as well. Now, if you add to this, you factor in also the aspect that each individual is going to have a different capability of digestion and assimilation, how can you possibly calculate how much calcium someone should be giving? Shoot from the hip? Oh, well, the RDA is such and such, so we ought to give them this much calcium. Or they're having such and such symptoms, so we're going to give them calcium. They got leg cramps, so let's give them calcium. Okay, well, what if it's not calcium that's causing the problem? What if it's magnesium? You give the wrong substance or you give it in excess of what's appropriate, you further imbalance the system. Now, one of the most ridiculous things I've ever heard is that, gee, you don't need to take that many vitamins because you're just going to pee them out. You're just going to have expensive urine. I can't even imagine how physicians who had any chemistry at all would ever say something like that. Because every single one of them knows what a catalyst is. A catalyst is a substance that is utilized in a chemical reaction to activate and speed the reaction, and when that reaction is initiated, that catalyst then is returned to its original form, as if it were untouched. Well, what do you think happens when we take vitamin C or vitamin B2? Would you imagine that those things would go into the body and have no action on them whatsoever other than just be excreted? That's a pretty silly thing to think. Well, for the same reason, just on the other side of the spectrum, would you think that, gosh, well, I'll take 1 pound of this supplement, and what my body doesn't need, it'll throw off. Now, why is that flawed? Because when you take a substance into your body, it has to be processed for excretion. One of the things that occurred some years back in the alternative and health food store markets, They got real excited about how wonderful evening primrose oil was for arthritics. And so they started recommending that. And arthritics started taking evening primrose oil, and for the first 60, 90, even up to 120 days, it was absolutely wonderful. Alleviated their pain. They felt great. Then all of a sudden, pain started coming back. Well, I thought, well, it's, I'm taking my EPO, must be something else. So they kept taking the EPO because it had alleviated their pain, and they started searching for new things to try and help them. What was happening biochemically? You start taking the omega-6s, and when you take an excess of them, you deplete certain enzymes, and in this case, primarily it's zinc in delta-5 desaturase. So you start depleting delta-5 desaturase, coenzyme zinc, and after a while, you change the biochemical route that omega-6 is following, and you end up with an increased production of arachidonic acid and increased production of PGE2, the very thing that was producing the pain in the beginning. Which is why eventually they started wising up, and now the recommendation is generally omega-3. But understanding where these pathways go and how they interact with other physiologic mechanisms is absolutely vital. If you take something or give something to a patient that is in excess of what is appropriate for their physiology, there's going to have to be a price to pay. You're going to deplete secondary cofactors. You're going to increase demands on detoxification. And you're going to create secondary problems, some of which may become obvious as other symptoms, but some that may not, some that you just may not connect whatsoever. So use some consciousness about this. The only way I know to monitor these things is to do laboratory testing. I didn't mention phytates and oxalates. This is a particularly interesting circumstance. Phytates and oxalates have an extreme high affinity, particularly for zinc. So if you are sufficient physiologically in zinc, and you're eating your food that has some zinc in it, then you're going to be able to assimilate enough to maintain an adequate level, presuming that you're relatively healthy and your assimilation is adequate and the balance of nutrients in your food is okay. That's a lot to assume, but let's assume that. However, if, say, you're under some unusual stress, whether it's illness, flu, automobile accident, psychological stress, whatever it might be, and you deplete your zinc. So now you want to therapeutically increase your zinc level. So you start taking zinc tablets. Well, when do you take them? You take them along with your meals. You generally take them in a multivitamin. Anytime you have zinc in the presence of phytates and oxalates, your zinc absorption drops to almost nil. Now, where do you find phytates and oxalates? Phytates are components of fiber. So any grain is going to bind with zinc and inhibit its uptake and just pass it right out through the stool. Where do you find oxalates? Well, you find oxalates in curious places like broccoli. Goodness, a healthy food. However, broccoli will bind zinc. The oxalates in broccoli will bind zinc and carry them right out through the gut. So what happens? People notice that, well, gee, that's not enough zinc. It's not doing what it's supposed to. Tissue levels aren't increasing. Okay, so let's give more. Let's give 100 milligrams of zinc. Wonderful. What happens when you give 100 milligrams of zinc? Well, you get a lot more into your system. Then what happens? Well, the extra zinc competes with copper for binding sites. So your copper levels, your functional copper levels drop. And what do you get? Depression. You begin to see how intricate all of these interactions are. What's an appropriate dose of zinc? Probably down about maybe 10 or 15 milligrams. So when's the best time to take it? Right before bedtime on an empty stomach, when it's going to be in your gut for the longest period of time. Now, what form of zinc? That's a whole other issue. You know, it's an interesting thing. We have, most of you, I'm sure, have either been to a magic show or have seen one. I guess now they call them illusionists. But we all know that there's something funny going on. but we're just absolutely compelled to watch what's going on right here. But we know there's something else going on, and we know there's something going on right in our vision, but because there's such a dance here, we don't pay attention to what's going on down here. Now let me tell you about an illusion in healthcare. They've done a number of studies showing how dramatic an increase in uptake of zinc there is when it's bonded to picolinate. It's like 8 or 9 times the uptake of zinc picolinate as there is of zinc citrate. Wow, fantastic. So we ought to use zinc picolinate. It's the dance up here. You know what's going on down here? What's going on down here is that zinc picolinate, the picolinate causes an increase of almost 20-fold in the excretion of zinc through urine. So not only are you not getting functional zinc in your system, you're dragging out functional zinc in your system through urinary excretion. Not the least of which is that picolinate doesn't have any viable use in human physiology. So it makes more sense to use some other form of chelate, even though the assimilation may be less, if the excretion or the stimulation of excretion is going to be less, is going to be more moderate. The end result is that you want to end up with increases in functional levels of nutrients in your system, not the non-functional ones. Now, additionally, we have the challenges of nutrient depletion. And I just put this one slide up, antibiotics, because we're all so familiar with it. But there are references that will tell you all of the different nutrients that are depleted by various drugs. And yet it's so curious, even though these are listed in the medical literature, that generally doctors and pharmacists don't recommend that the nutrients be additionally supplemented. I'll mention these earlier. I'll just list them. In addition to all of the other considerations, we have a variety of nutrient demand variables for each individual. Not only is their genetic makeup have something to do with it, but a whole raft of other considerations also come into play. Heavy work or physical exercise, very warm or cold climates, aging and the aging processes, health problems, metabolic disorders, chronic diseases, injuries, and the use of drugs or alcohol, recent surgery, or unique genetic demand. It starts to paint a picture that you can't treat two people the same. You can't guess at what one physiology, at the level of performance of one person's physiology over another unless you have some detailed information. Only way I know how to do that with precision is through laboratory testing. So what we want to do then is we want to adhere to a new paradigm of understanding in analyzing human biochemistry and functional operation, beginning with specialized metabolic testing, using interpretive analytical reports that do more than just look at a single line item. Use individualized nutritional products. Instead of just dragging off, okay, well I give everybody this calcium supplement or I give everybody this magnesium supplement. If you understand an individual's unique demands, you're going to better be able to individualize the program for them. Use optimum quality standards, not those standards which are merely the absence of disease. Use adequate supplementation, not illusion, such as we talked about with zinc. Assess a variety of different aspects of metabolic function, not just simply looking for disease, but look for things like protein degradation, detoxification ability, nutrient density, oxidative stress, immune regulation, hormone balance. Make this your new paradigm. Look for optimal function. Now, one of the tools that we use that can be so effective is a comprehensive chemistry. Now, granted, this chemistry is a little bit more comprehensive than physicians generally ran even in the old days when they could. But still, most practitioners in the alternative medicine community have become rather jaded about this. They become rather jaded because they've been accustomed to looking at a chemistry with a view of high or low within reference range, and so it doesn't tell them anything. I'm here to tell you that there's a massive amount of information in a standard chemistry if you use a multifactorial assessment. Why would you want to order the test? First of all, to establish a baseline. You want to use it also to aid in determining progress through comparison reporting. Now, there are tools out there where you can do comparison reporting. If you try to put two lab tests side by side and compare the percentage variation from the mean in a pattern deviation, you're going to have a tough time. So you need a computerized tool, and they're available. It'll also help you to determine which system is most out of balance. Now, the limitations, there are limitations and there are strengths to this. Limitations being that there is some potential for error due to specimen handling, which of course you have in any laboratory test. Insufficient specificity for fine metabolic tuning. However, the broad view is both a limitation and an advantage. We have a tendency to get too reductionist in our approach. You know, we look at the leaf and we say, well, I know the character of the tree. Well, in human physiology, that's not always true. We need both the view of the forest as well as looking at the trees and the leaves. A comprehensive chemistry will give you a good look at the forest. It'll help you to recognize things that you might otherwise miss. Secondly, we recommend an amino acid 40 plasma. It gives foundational information on metabolic capability. It allows for highly specific recommendations, and it provides information on the primary nutritional emphasis in a complex case. And we're going to talk some more about that shortly. This is why amino acids are so critical. In all of these functions, amino acids are the foundation. They are the origin. They're the first place. If you're not analyzing amino acids, then you're missing something. If someone is missing key amino acids for the production of glutathione, how do you think their detoxification is going to be? If they're missing key amino acids that are important in, or they're deficient or imbalanced in amino acids that are key in gluconeogenesis, how do you think we're going to produce energy? It isn't going to happen efficiently. Organic acids in urine is the next one we recommend. Organic acids are metabolic intermediates normally present in small amounts, if at all, in urine. When enzyme reactions are blocked, organic acids accumulate and increase in urinary concentration. Now, does this give you a clue? If you are able to find certain organic acids in urine, you can pointedly identify where the metabolic reactions are blocked. Now, wouldn't that be important stuff to know? In fact, in every case where an enzyme defect involves the binding of a mineral or vitamin-derived cofactor, it is highly likely that affected individuals will be responsive to nutritional therapy, as long as it's targeted. Organic acids is a first morning urine collection, so it's relatively simple. It is universally accepted for the study of metabolic disorders. It provides the greatest array of metabolic byproducts of any test that I know of. It manifests intermediate conversion competence, which allows you to study not just end products, but the significance of interactions that occur on an intermediate basis. Now, historically, the application of organic acids has been to identify and monitor severe inborn metabolic disorders in infants. However, what we've done is we have expanded its use And we use it for the detection of nutrient imbalances prior to functional impairment. Now, as you can see, there are a whole lot of systems that can be assessed by an organic acid panel. B vitamin groups, certain amino acids, neurotransmitters, trace elements, dysbiosis. This is a very important aspect we're going to discuss this morning. Xenobiotic exposure, and fatty acid metabolism. So, as a functional assessment that is non-challenge, organic acids is by far the superior test to anything that you have access to. Simple collection, broad analysis of a variety of intermediate conversion aspects. So the sequence we recommend: comprehensive wellness profile, plasma amino acids, urine organic acids, and then after your best efforts to intervene to improve the amino acids and the nutrient cofactor interactions, then and only then might you choose to go on to additional testing. If you don't lay that foundation, you're simply going to have a lot of failures in your therapeutic approach. Comprehensive chemistry will identify gross pathology, which is a responsible thing to address. It'll identify immediate or urgent concerns, contraindicated supplements, some dietary contraindications and guidelines, clinical correlations that may be used as a guide for diagnostic coding, wealth of valuable information, and will enable customization of an electrolyte formula. This is why we put the comprehensive chemistry first. One of the major problems, and I'm sure you've seen people who come in with 30 bottles of supplements and they're taking them all and they're still sick. Their tissue levels of nutrients, their functional levels of nutrients are really irregular, deficient. Why? These nutrients can be assimilated and utilized in a relatively narrow pH range. If your pH is off, if the electrolyte balance is off, you're not going to assimilate and utilize those nutrients. So that's one of the first places you need to address. You want to address getting the electrolytes back into a proper balance. A lot of nutrients, say taurine for instance, taurine by itself will not cross the blood-brain barrier. Won't do it. You know how it gets across? Sodium and potassium carriers. So the electrolytes are a very important initial consideration. And that's one of the things that you can do with a comprehensive chemistry. You can customize an electrolyte formula for that individual based on this information. Amino acids are foundational elements to the proper functioning of many metabolic processes of the human body, as you've seen. If the amino acids are inadequate or imbalanced, higher orders of chemistry are likely to not respond as favorably to nutritional balancing. I might be more firm and say they're not going to. You wouldn't build a second story of your home before the foundation, but it seems like in medicine what we try to do is go in and put the cabinets on the second floor before we've done the foundational work. If somebody has a malabsorption syndrome, and I see this all the time, they have malabsorption syndrome, which is very close to malnutrition, and yet practitioners have done everything else for them. They've gone and done antifungal therapy, their pH is off and they're giving them 20 supplements at once and so on and so forth. If you don't lay the foundational issues for improved assimilation, utilization, and address amino acid deficiencies, how do you expect you're even going to build healthy epithelial cells once you kill a fungus or a pathogen? Can't happen. First, balance and build up the amino acids, giving the body ample supplies of necessary building blocks. Then determine the cofactors that are needed to begin to further balance the individual's chemistry. Urine organic acids test is helpful in determining cofactors and metabolic impairments, as well as functional ability to deal with bacteria, yeast, fungus, and importantly, very importantly, clostridial pathogens. And we'll talk about this briefly in a little while. It identifies functional management of dysbiosis rather than simply the presence of potential pathogens. And I've got a slide where we're going to talk a little bit more about that too, and it's right here. Questions often asked me, okay, so why would you want why would you prefer to do a urine organic acids over a comprehensive digestive stool analysis? And there's some good reasons. First of all, most of the critical pathogenic activity is in the small intestine, far removed from where you get a stool specimen. And there are a lot of things that can be missed because of that. There is a substantial bacterial shift at the ileojejunal junctions. Urine measures toxic byproducts versus direct bacterial measure of stool. Now, you can pull a pathogen out of a stool specimen. Can you answer from that the question, okay, is this person reacting pathogenically to this otherwise considered pathogen? And we ran across this a lot of times more than a decade ago when I was seeing a lot of stool tests that came back with Blastocystis hominis. And some people would be just sick as dogs, and other people just had no problems whatsoever. And it was because, for whatever reason, their physiology was capable of managing the circumstances. It was able to manage the fact that there was blastocystis in their gut. Now, was it because there wasn't that much blasto, or because they had some special defense mechanisms? I'm not sure. What I am sure of is that when you do a urine organic acid profile, you get metabolic byproducts that will clearly tell you whether or not that individual is responding adversely to a pathogenic intrusion. And it's those pathogens that you want to address, not some illusion that may be going on down here somewhere. Now, there are a couple of labs that do very good work with stool, and probably all of you know about them and use them. However, even for them, it's very difficult to properly culture anaerobes in a stool sample. It's rarely done properly. You know, there's only about, the mass of stool that's used, only about 1% of that is useful in identifying the pathogens that we're looking for in the small intestine. So it's a difficult process, and even once we do it, we don't know the level of pathogenicity of that organism for that given individual. But a urine organic acid test will tell you. Okay, amino acids, the functional significance. I'm not going to read all these, but there are a whole lot of systems. In fact, can you tell me a system of the human body that is not impacted by amino acids? They all are. Hormones are constructed from them. Muscle tissue is constructed from it. Amino acids are integral to everything that goes on in our systems. Now, the reference ranges for amino acids are based on nitrogen balance studies in healthy individuals. They're predicted on the smallest amounts compatible with normal size growth in infants and children. Published estimates show a wide range of variable needs in a given individual, even within a single study. Now, this is why a lot of the amino acid products out there on the market don't work. Now, by don't work, if you're deficient in amino acids and you take an amino acid formula within hours, certainly within 3 days, you ought to notice a dramatic change. Now, why is it that that doesn't happen? All of the studies that have been done on amino acids and all of the amino acid products that, almost all of the amino acid products that are produced, are done so based on ratio relationships that have been identified in nitrogen balance studies on healthy individuals, not on chronically ill people. I did a study, review study of just over 10,000 laboratory tests that we got back on amino acids. And in that evaluation, I found certain characteristic patterns of abnormality in amino acid balances in chronic individuals. Those relationships of the amino acids are substantially different to the ratio relationships that are characteristic in amino acid products. Now, when we adjusted for that and created an amino acid formula that was designed around these principles, what we got was responses that occurred anywhere from hours to a few days of increased energy, alleviation of symptoms, all sorts of things occurring. Now, additionally, subtle effects on neurological and psychological function are rarely even considered in published studies. Now, here's an example. I'm going to show you several examples. I'm going to run through it pretty quickly, but here's one example of a pattern of abnormality in regard to amino acids that would show no values out of reference range. However, this is hepatic encephalopathy. This is a pattern of spleen deficiency syndrome that would show no values out of reference range. That, by the way, that's a serious amino acid deficiency syndrome. That's malabsorption. Now, how in the world would you figure that this individual could function well under normal circumstances of minimal stress, let alone under the stress of chronic disease? Here's a pattern of poor quality diet, inadequate digestion and assimilation, increased hepatic synthesis, reduced skeletal muscle activity. Okay, now a question has arisen, well, gosh, you can just throw these numbers up just based on some arbitrary estimate. Well, I suppose I could, but in fact, all of these patterns are directly from published peer-reviewed study that's been issued in journals like New England Journal of Medicine, Lancet, Journal of the American Medical Association, and so on and so on. These are all patterns that have been identified and published as being abnormal in spite of the fact that they do not exceed 2 standard deviations from the mean. This is a pattern of hydrochloric acid deficiency which would not show up as an abnormality on a standard test. Pattern of pancreatic enzyme deficiency and zinc deficiency. Characteristically, tryptophan is just about perfect. This is a pattern of B5, B6, and zinc deficiency, where the branched chain amino acids are elevated, but once again, not outside of reference range. This is a pattern of chronic depletion of B5, B6, zinc, branched chain amino acids, and results or is represented by the loss of muscle mass, reduced hepatic synthesis, and sometimes resulting in alopecia or sleep apnea. Now, there are a number of cofactor indicators that you'll find, some of them in urine, some of them in plasma, when testing for amino acids. But once again, you look for ratios and relationships, and because of the metabolic pathways that are involved, it can be very clear what the cofactors are that are deficient, which allows you to be able to target your therapies. And subsequent follow-up will tell you whether or not that's working very clearly. Now here's kind of a simplified diagram of catecholamine synthesis, which I wanted to kind of go over with you to show you the significance of amino acids and a variety of functions. Phenylalanine is converted to tyrosine in a reaction that is dependent upon niacin, folate, which are those are the precursors for biopterin, and iron. If those are absent, you're going to have low levels of tyrosine. Tyrosine, in a reaction with iodine, forms thyroxine. So if you have a hypothyroid patient, what should your first consideration be? Give them thyroid hormone? How about check to find out if they have adequate levels of tyrosine and phenylalanine, iron, and biopterin precursors? 40% of thyroid hormone conversion from T4 to T3 occurs in peripheral tissue. Now that means outside the thyroid, in the liver and the kidney, primarily in the liver. 40%. that conversion of T4 to T3 is tyrosine dependent. So if you're tyrosine deficient, you are going to be hypothyroid. You're going to be functionally hypothyroid. Just as if you're iodine deficient. Now the other character in here, which I don't have on the chart, is selenium. Selenium is on this conversion line between tyrosine and thyroxine. If you're selenium deficient, your T4 conversion is not going to go to T3, it's going to go to reverse T3, an inactive form of T3, a storage hormone. And so once again, you're going to be functionally hypothyroid. So the first place, obviously then, if you're assessing hypothyroid conditions, would not be just look at TSH. Would be to look at some of the precursors that are absolutely essential in the formation of thyroid hormone and its function. Now additionally, tyrosine also is converted to melanin in a copper-dependent reaction. Tyrosine then is converted to dopa in a biopterin iron-dependent conversion. Dopa to dopamine in P5P with P5P, B6. Dopamine to norepinephrine, dependent upon vitamin C and copper. And norepinephrine conversion to epinephrine on an S-adenosylmethionine dependent conversion. So if you begin to look at this, what you see is that there are a lot of cofactors, all of those that are in green, a lot of cofactors, along with the key amino acid factors that can have a substantial impact on a variety of mechanisms. Thyroid hormone, melanin, neurotransmitters. So doesn't it make sense to do more foundational assessment before you intervene later down in the pathway? Just a couple of tips. Low taurine suggests excessive oxidative damage. Chronic deficiency results in extreme sensitivity to environmental allergens. These are the people you find that are universal reactors. Get a universal reactor, you can get some taurine in them, you're going to reduce their sensitivity. It's a key component of bile. Low taurine can result in problems with fat digestion, lower fat-soluble vitamins, and elevated cholesterol. All mechanisms that we use other circuitous routes to address, HMG-CoA reductase inhibitors, when maybe what it is simply some irregularity, some imbalance in amino acids. Low taurine contributes to a host of cardiovascular and neurological problems. Low taurine increases platelet aggregation. Beta agonist drugs reduce stores of taurine. You get somebody on beta agonist drugs, they're going to be taurine deficient. Low glutamine suggests ammonia buildup, even more likely when elevated glutamic acid is in their panel. Low carnosine and an elevated 1-methylhistidine indicates functional zinc deficiency. It is very specific. Now, how else do you find functional zinc deficiency? About the closest thing that I've ever seen is white cell zinc. But then once again, you also have this, have the transience of the white cell impairing your ability to accurately assess zinc functionality. Elevated ethanolamine and depressed phosphoethanolamine indicates a functional magnesium deficiency. These are just some of the possible myriad of details that you can learn about functional nutrients from an amino acid profile. Elevated alpha-aminodipic acid is by itself the #1 premier best cardiovascular risk disease marker, superior even to homocysteine, superior even to C-reactive protein, all by itself. And it's specific to B6 deficiency. It's seen in impaired lysine metabolism and may be connected with neurological disorders. Now let's talk for a few minutes about organic acids. Now, you saw quite a list of systems that were analyzed by organic acid analytes. There's a tremendous amount of information, even more information on an organic acid panel than can be extracted from an amino acid panel. So you really kind of have to focus. And these are the basic questions that you want to ask in regard to an organic acid panel. Is mitochondrial energy production adversely affected? Are functional nutrient deficiencies present? Are symptoms related to excessive growth of bacteria and fungi in the gut? Is there an undue toxic load, and is this adversely affecting detoxification capacity? Now, I challenge you to point out to me any other single analysis for the cost of what you can get an organic acid profile that'll give you this kind of information, this kind of comprehensive information. Dicarboxylic aciduria, I have to clip through here, can be identified with organic acid analysis and results in a series of symptoms, including fatigue, mild muscular weakness, nausea, recurrent infections, hypoglycemia symptoms, sweaty feet odor, Ray's-like syndrome due to effect of viral toxins on mitochondrial function. Now, how many of your patients does that fit? Now, the interesting thing is that once you identify these things, it will give you specific pathway abnormalities that will allow you to target cofactor intervention. Ketone body production is also analyzed with organic acids. And very important here is the identification of insulin insufficiency. Energy production and enzyme cofactors. Lactate elevates with the final stage of oxidative phosphorylation blockage in energy production. Results in an inactivation of the TCA and is initiated in a variety of metabolic problems. Pyruvate is involved in the anaerobic breakdown of glucose, requires pyruvate dehydrogenase to convert to acetyl-CoA, and reflects functional cofactor deficiency. Now, organic acids, and particularly organic acids in combination with amino acids, is one of the few methods where you can get a precise, well-documented differential diagnosis of B6, B12, and folate deficiencies. Elevated methylmalonate is clearly a B12 deficiency when it's by itself. If the homocysteine is the only one that's elevated, it's both B6 and folate deficiency. If they're both elevated, it's B12 and folate. And I've got a chart here. If I get time, I'll show you how you would identify specifically folate deficiency when B12 sufficiency was adequate. Cholesterol synthesis, I mentioned this in passing. HMG, which is an organic acid, hydroxymethylglutarate, is a precursor for the synthesis of cholesterol and CoQ10. Lowered HMG reflects inadequate synthesis of both. The statins all block utilization of HMG and lower CoQ10. So what should that tell you? Everybody who's on a statin ought to be on CoQ10 because what happens? They take a statin to block cholesterol, okay, so they have reduced cardiovascular risk. It depletes their CoQ10, which increases cardiovascular disease risk. Doesn't make a whole lot of sense, does it? Elevated HMG excretion suggests CoQ10 synthesis inhibition. CoQ10, of course, is needed for oxidative phosphorylation pathway to ATP synthesis and is a potent cardiovascular antioxidant. Now, this chart kind of represents deficiencies in the production of nutrient cofactors as a result of dysbiosis. On the left, you see levels of production of B1, B2, B6, magnesium, and zinc in a normal individual. On the right, you see how restricted the production of these cofactors are in an individual with dysbiosis. So if you've got dysbiosis, your production of cofactors is going to be reduced. Now here's a chart with the metabolism of tryptophan. Tryptophan also, in its conversion process, requires biopterin, which is, once again, folate and niacin dependent. Now in the conversion to 5-hydroxy-L-tryptophan, from 5-hydroxytryptophan to serotonin, pyridoxal 5-phosphate is the cofactor that's necessary for that conversion. Then as a result, as the serotonin levels increase, 5-HIA, 5-hydroxyindolacetate, is excreted, and that's measured in an organic acid panel. So you can effectively measure the adequacy of the processes that produce serotonin with an organic acid panel. Now here again, and I won't go over this again, we talked about this some, but what I meant to do is just notice now, in this whole process, we bring ourselves down to the neurotransmitters dopamine, norepinephrine, and epinephrine. And each of those has an organic acid byproduct. So if you have insufficient levels of homovanillate, it is a clear indicator that you're not producing dopamine. And if the vanilmandylate is low, you're not producing epinephrine or norepinephrine. If, however, homovanillate and or vanilmandylate are excessively elevated, it's telling you're producing a lot of dopamine, a lot of epinephrine and norepinephrine, and you're depleting tyrosine reserves, at which time you'd have to increase the tyrosine supplementation. So you get a lot of indicators here that can help you to understand neurologic balances, understand neurologic abnormalities, without being invasive. And you get functional assessments. Increased 5-HIA excretion does occur in the use of SSRIs, and it increases when, in the release of serotonin from the CNS, platelets, are gentafin cells in the gut also. Well, what's one of the functions of serotonin? Gut motility. So if you've got elevated levels, which is, for the last year I've been specializing primarily in autistic spectrum disorders. And one of the characteristic things we see in these children is that they have high serotonin levels. And what do they also have? Diarrhea, chronic diarrhea, all related to the serotonin excess in production. Intervention. You can increase hydrochloric acid. You can add pancreatic enzymes. You might recommend tryptophan foods and 5-hydroxytryptophan supplementation. But what might you also do? You might also assess amino acids, determine if there are sufficiencies or imbalances, and address those, even before you would recommend hydrochloric acid supplementation. In the scheme of this approach, HCl should be a temporary intervention while you address amino acid deficiencies and correct them. Low homovanillate indicates low CNS levels of dopamine, and your intervention there would be to improve protein digestion, supplement amino acid precursors, and supplement amino acids. Low vanilmandylate indicates low CNS levels of epinephrine and norepinephrine, which would result in fatigue, sleep disorders, depression, and difficulty managing stress. Now, the detoxification markers that are on an organic acid panel include glucarate, orotate, p-hydroxyphenylacetate, 2-methylhypurate, pyroglutamate, and sulfate. Glucuronidation is an important detox mechanism when sulfation or glycination are impaired. Glucuronidation is really the fallback position. It's the one that your body will go to if the other pathways are compromised or amino acids that deliver those functions are deficient. But glucuronidation isn't a bottomless hole. Now, you don't necessarily want to rely on glucuronidation because its speed of processing toxins is substantially less than the other pathways. So the efficiency is less. So you're going to be more toxic if you've depleted the other pathways and you're relying on glucuronidation. Glucarate is an oxidation byproduct of phase 2 liver detoxification reactions. Suppressed levels indicate depressed overall hepatic function. Increased levels indicate enzyme induction, which indicates that you've been exposed to xenobiotics. Cytochrome P450 induction can occur with food components, drugs, gut microbe, metabolic byproducts, and xenobiotics. And it's a useful biomarker for xenobiotic exposure. Organic acids can also tell you about ammonia detoxification. One of the critical aspects of this, which also is involved in immune regulation, immune system regulation. Carbamoyl phosphate stimulates the synthesis of orotate when you are unable to adequately detoxify ammonia. An elevated orotate is a sensitive marker for the depletion of arginine. Now, what happens when arginine drops? Immune response decreases. Arginine supplementation alleviates ammonia toxicity symptoms, and orotate requires magnesium for metabolism in the mitochondria. Increased orotate indicates functional magnesium deficiency. Now, magnesium is one of the toughest nutrients, one of the toughest cofactors to accurately assess its functionality. With an organic acid panel, you have a number of markers that will tell you about magnesium functionality. P-hydroxyphenylacetate. Now, here's this chart shows on the left before treatment and after treatment the levels of abnormality in a variety of areas. Now, this is particularly interesting because in a study of several hundred individuals, they determined that p-hydroxyphenylacetate was specific to identify Giardia infestation. And in fact, there were no false negatives, and there were only 2% false positives. So it means that p-hydroxyphenylacetate is an extremely accurate marker for Giardia. And you know how tough Giardia can be to identify in stool specimens. Also, you can identify toxic solvent exposure through elevations of 2-methylhypurate. Now, pyroglutamate is an organic acid. It's an intermediate in the active transport cycle of renal tubule uptake of aminos. When the cycle is impaired, the glutamic acid portion of glutathione is converted to pyroglutamate and excreted. This conserves amino acids at the expense of glutathione. Now, N-acetylcysteine can help to rebuild stores of glutathione, but I never recommend it unless you're already on some balanced base amino formula. Otherwise, it can further disrupt amino acid balances and cofactor availability. Low-dose heavy metal exposure may increase excretion of pyroglutamate. Now, this is all pretty important because if you're seeing elevations of pyroglutamate, you know that glutathione is being compromised. Sulfation, phase 2 biotransformation of drugs, hormones, phenolics, etc. The sulfate to creatinine ratio is used to estimate sulfur reserves, including glutathione. Now, here's a kind of a brief chart just to show you where these things go on. Xylene results in 2-methylhypurate. We have a series of reactions that occur in phase 1, some in phase 2, and also renal amino acid recovery, all of which can be tracked through the use of organic acid byproducts. There are a number of intestinal dysbiosis markers. I'm going to go just a few minutes past since I haven't used up my hour and a half yet. A number of them are specific. Some of them can tell you if there are additional impairments to the accessibility of nutrient cofactors. Particularly important is dihydroxyphenylpropionate. Dihydroxyphenylpropionate, DHPP, is a metabolic byproduct of Clostridium pathogens. Now, there are about 100 different species of Clostridia. 50 of them so far have been identified as being pathogenic. There may be more. What's curious about this is that Clostridium is seldom identified. Even the one most commonly known, Clostridium difficile, which is generally the only one that's assessed in stool specimens. But we got the other 49 plus pathogenic forms that also produce DHPP. Well, when you have a Clostridium infection and you give a patient an antifungal, characteristically what you'll see is that the patient will probably improve. But as soon as you take them off the antifungal, they get worse again. I don't care if you've had them on it for a year. The reason for that is that the Clostridium has created problems. Now, why is that significant? DHPP is an analog of norepinephrine and epinephrine. In other words, your body recognizes DHPP as a neurotransmitter, but it won't work like norepinephrine and epinephrine. So you have an inadequate production and utilization of your neurotransmitters because your body is sensing you've got enough neurotransmitter already. So this is the reason why you have some serious abnormalities in that regard, and why you can put a patient on an antifungal therapy and improve a lot of symptoms but get increased problems neurologically or emotionally. So the answer to that is address Clostridium first. Now, the only way I know to effectively be able to identify Clostridium most of the time is through an organic acid panel. You identify it, you need to address Clostridium at least first or simultaneously with fungus, or you create other problems. I'm going to take an aside here. We may not finish all the slides, but this is very important. And it relates somewhat to this whole idea of addressing gut pathogens and bowel terrain. Yeast organisms, perhaps Candida, but I haven't had any direct evidence to believe that it's Candida per se, although because of its complex biochemistry, it probably is a culprit in this as well. But yeast that you find in the gut does produce an analyte called arabinose. Arabinose is a 5-carbon sugar. Now, you might remember 5-carbon sugars as a culprit in those studies that have been done regarding pentosodine formation in neurofibrillary tangles and plaques in Alzheimer's disease patients. Let me tell you what I think is going on here. About 50% of the enzymes in your body are epsilon amino acids. They are lysine terminating enzymes. Now, if these lysine terminating enzymes bind with arabinose, which is a 5-carbon sugar, that's characteristic high affinity for these epsilon amino acids. Number one, it inactivates that enzyme. Now, that reaction can be reversed. That arabinose can be released from that lysine terminating epsilon amino acid. However, there are other binding sites there on the 5-carbon sugar, and it has a high affinity then for an arginine terminating molecule. Now, if an arginine then attaches to that 5-carbon sugar that's already attached to an epsilon amino acid, that reaction is irreversible. Our physiology doesn't know how to reverse that reaction, and in biochemistry, in pharmacology, we don't know how to reverse that reaction. Now, that's not such a big problem when there are 2 proteins attached to that arabinose, but it doesn't stop there. You can get dozens of proteins attached to that. Now, what happens then? Number one, it becomes such a big glob, such a big mess, your body recognizes it as an invader. It's an allergen. So you got those problems. Now, additionally, say for instance, this pentosodine, which is what this is called, what this formation is called, this glob of cross-linked proteins, say for instance that's in a neuron in your brain. Well, this protein becomes so heavy that it tends to drop out of solution. So when you've got these proteins dropping out of solution in neurons in your brain, that's not a very good thing. And in fact, what this is are those pentosodines that are characteristic of the plaques that you find in Alzheimer's disease. Now, where does this all come from? When you do antifungal therapy and those lysine terminating epsilon amino acids are not adequately protected, you release arabinose into the system, it is absorbed into the bloodstream, binds with these amino enzymes, creates an irreversible reaction, and you have just created irreversible damage. So what protects these epsilon amino acid enzymes? B6, biotin, alpha-lipoic acid. Now additionally, what you also want to consider is that what I've been describing is what is commonly known as die-off reaction, Jarisch-Herxheimer reaction. Herxheimer reactions are not innocuous. They are not innocuous. They have the potential for creating permanent, irreversible neurologic damage. Now, the hogwash that I've heard over the years about you got to get worse to get better is sheer ignorance, and it's dangerous. Understand that you do not want to initiate Herxheimer reactions if you can help it. Now, sometimes it's unavoidable. Sometimes you have to crack an egg to make an omelet. But if it's at all possible to enhance and improve detoxification pathways, to make sure the gut is clear, you don't ever want constipation in one of these people. Have them do fleets, have them do colonics, have them do whatever they have to do to keep that bowel movement moving. Because otherwise what you're going to be doing is you're going to be creating irreversible damage neurologically. Now, to what extent? That really depends. Maybe what it's going to be is in 15 or 20 years, shortening of life, increased risk of cardiovascular disease, increased incidence of Alzheimer's or Parkinson's. Maybe in a youngster it's going to result in a drop of 20 points in IQ. But it's undeniable. This is simply a biochemical fact. Okay, benzoate is converted by glycine to hippurate in phase 1 oxidation reactions. An increased benzoate, which is real common, suggests that you need suggests that you have lowered glycine and that you need to supplement. Let's see. One of these byproducts, cresol, is extremely similar in chemical structure to phenol, and it's highly toxic. And when you find a patient who has elevated cresol in their urinary organic acid panel, you've got one tough case. Tricarbolylate is produced by prolific aerobic bacteria. It binds so tightly to magnesium as to induce a deficiency when an overgrowth is present. When you find an extreme high level of tricarbolylate, you can expect that this person is going to be severely magnesium deficient functionally. Okay, we talked about that. And if there are other things that you want to talk about in regard to this, if you'd like some help figuring out how to structure profiles in your practice, give me a call. You have one flyer in front of you, I hope. If you don't, you can pick one up outside, or you can pick up one of my business cards up front here. We do produce an interpretive report that Chris referred to earlier that shows all of these sensitive variations in abnormalities and does a multifactorial analysis and calculates what are appropriate foods or inappropriate foods, appropriate supplementation, which one should be avoided, where the complications are in the pathways, and so on. I also do, I'm a professor for 2 universities in nutritional biochemistry. I do conduct classes around the country periodically, and I have my calendar posted on the web, and if you call or send me an email, they'll give you that address. And I thank you for your attention, and I hope what I've had to deliver to you is helpful to you in your practice. Thank you. Questions?
We'll save them for the panel discussion afterwards. 20-minute break. Dr. Russell will be on after Gary. Thank you, sir.